Good morning, everyone. Hi, let's go ahead and get started. So welcome. We're kind of getting to the end of the morning, but I guess we're starting the morning. It's been a long weekend. But so I'm going to speak today about kind of making medication decisions in X and Y variations, and then once those decisions are made, to do a trial of medication, kind of how I recommend going and approaching it, and some ideas for you guys. I'd love to have some time for questions at the end. I'm going to be spending a little bit of time talking about some specific medications, and I know there was also just a talk of part one. Dr. Hong and I coordinated kind of the topics, but unfortunately I wasn't able to be at his talk. So if there's anything that's very repetitive or he said I'd talk about that I don't, then hopefully we can cover those things at the end. So we're going to go overview of different conditions treated with the medications. We're going to talk about making medication decisions, symptoms, nuts and bolts. Through here, there's also some introduction to medication classes, some resources that I use to kind of monitor medications, and then also as we go through, we'll talk about some case examples. Not exactly in this order, though. So this is all kind of throughout the presentation. I'm not endorsing any specific types of medications. I do and have done a lot of clinical trials and consulting for different pharmaceutical companies for trials in Fragile X syndrome. The science in these conditions is not there yet where we're doing any specific medication trials for X and Y variations. But hopefully one day there will be good clinical trials that are specific to the neurobiology of the X and Y variations. And then obviously I can't make any specific recommendations today for specific individuals. So this is a general talk, and I can talk in generalities about treatment of symptoms, but specific treatments, since if I'm not your provider, I am not allowed to make. So the way that I usually and always talk with families about conceptualizing all the different risks in these conditions is that the genetic condition is on the top. So whether you have XYY, XXX, XXY, XXYY, the primary condition and sex chromosome variation is on the top. The differences, because you have an extra X or Y and or X or Y chromosome that comes from those, it leads to overexpressions of genes on those chromosomes. Those genes lead to differences in the way that the brain develops. And once there's differences in the way the brain develops, there can be an increased risk for many different things. And so this leads the increased risk for cognitive and learning differences, developmental delays, social developmental differences in terms of social maturity or autism spectrum disorders, and then behavioral and emotional differences such as short attention span, distractibility, hyperactivity, impulsivity, anxiety, depression, sensory sensitivities, and other irritability, obsessive compulsive or repetitive behaviors. This combination up here is often referred to as ADHD, but these are all the risks. Clearly not everybody with sex chromosome variations have all of these things. If some of the behaviors are present, such as a short attention span, it doesn't necessarily mean it is ADHD for sure. And there's a lot of variability, as you guys know, in terms of what symptoms different kids and adults present with. Whatever the diagnosis is, it's important to think of a treatment plan that is definitely not just about medications. So while we're talking about medications here today, I always feel like medications are a small piece of a pie in a treatment plan, and sometimes not even a piece of that pie, right? There are not all these different symptoms do not need to be treated with medications in everybody. And so part of the process that I go through when I'm evaluating patients is part of what we'll go through today as a group to be able to really think about, when are these times that maybe a trial of medications might be something to think about to add to that pie. The other pieces of the pie, clearly, and obviously all of these pieces depend on the child and the type of symptoms that you're treating, but generally, academic supports are clearly a big piece in many of the children. OT, speech, behavior therapies, other types of either complementary types of therapies or services, and then medications as well. So, whenever we're trying to approach a child, we want to, or, adult, all of this applies to adult. I work with kids, and so I tend to speak to pediatric audiences, but if any of you feel like, oh no, my son's an adult or my daughter's an adult, this is just as applicable to adults as well. The other really important thing is that this pie lives on a family and home environment as well, right? And so whatever the treatment plan is, it sits on this base of what's going on in the family. This, I think, is really important to talk about. If you have this really unstable pie on top of this really pointy, the pointier this is, the more likely your whole pie is to just roll off and fall down. So this means you guys have to take care of yourselves as well. And sometimes when we see that some of the developmental or behavioral challenges and academic challenges that come with taking care of a child with an X and Y variation leads to a lot of stress at home, addressing the stress at home, helping your own self be comfortable with how you're going to be able to manage your anxiety or your own challenges, keeping the environment safe and calm for the rest of the siblings and the rest of the family is going to make this pie work more consistently. And so, I think that everyone needs to, sometimes this is more important than medication, or this is more important than, oh my God, I got to get to speech therapy 4 times a week, right? And so if some of these pieces of the pie are causing this problem too, it can go both ways. Okay, so when should medications be considered? This is, when families come to clinic, we always think about, whether or not medications might play a role in helping certain parts of the symptoms. And these are kind of my top 5, and then there's always one at the bottom that's clearly important. We're going to talk about these in more detail, but basically whenever a behavioral symptom, so any of those ones listed, anxiety, hyperactivity, distractibility, is causing and significantly impacting any of these areas, it's when I start to think about whether or not medications might be helpful. It doesn't mean, again, it's necessarily going to be started, but health and safety concerns, academic and learning concerns, therapies, participation in the family and community, social development or social interactions, and then obviously when the child is expressing or demonstrating distress about the emotion or behavior. We're going to go through all of these in more detail so you get the idea of what I mean by impacting and significantly impacting. But basically the important things are that it doesn't have to be all of them, right? We just have to think about the behavior in all of these settings and then use that as a rule to figure out whether or not we want to move on with the trial of meds. So before we even start meds, there's a lot of common parental concerns. When I bring up medications with some families, they're very comfortable with the idea of using a medication for behavior or anxiety because they've used them in their family or they've known people who have been on them and it's been, it's been helpful for either themselves or for others. For others, it's, oh my gosh, because there is still, I think in our society, a stigma about psychiatric medications, right? I don't want to put my kid on drugs. We're not going to fix this with drugs. And it's there still is a stigma that we live in and a lot of common concerns. So I know all the common concerns, but I want to hear from you guys what you think are the common concerns that people bring up when we talk about, concerns about starting medications. Yeah.
I asked this to the last session, and he said to wait for you. Our XXY boys who are diagnosed with ADHD, are they treated the same as other boys that aren't XXY for the ADHD?
We will talk a lot about that later, but yes and no. Okay, when someone presents with ADHD. That means that they have met the criteria for a checklist of symptoms, right? Okay, he is distractible in class, yes. Does he fidget around and need to get out of his seat frequently? Yes. And so, you go through what those criteria are. What's important is that the symptoms of inattention, I'm looking around, I'm not paying attention, I'm not staying focused, do not always mean you have a primary deficit in attention. If you're in a class, they often can sometimes be symptoms of other conditions that are more important to treat. If you have a learning disability and everything in that class is kind of going over your head, or it's really hard to grasp onto some of it, you get some, but the rest is like, oh my God. Well, they're not going to pay attention, right? And so I don't pay attention in lectures when they're way over my head. I'm like, I'm trying, and then I'm like, I can't do it anymore, right? And so you end up on your phone. And so, so that's true in a classroom setting too. And so I think it's always really important to rule out learning disabilities. It's also really important to rule out anxiety. If you're really anxious about what's going on, if you have sensory sensitivities and oh, it's noisy over there, you're going to be more sensitive to that, you're going to be more distracted. And so any of the other symptoms are really important to evaluate instead of just using that checklist for diagnosis. That is one thing I think is probably different than in a primary or in a kid without an X and Y variation. Personally, I think anyone diagnosed with ADHD should have a big, huge evaluation. But current pediatric practices, if the teacher says that ADHD is present based on their checklist and the parents also see it at home, it is acceptable to then make a diagnosis and then move on. But I do think because there's so much complexity with the X and Y variations, you want a little bit more evaluation before you say, okay, this is going to be attention. It might be part of it for sure, but it's definitely not always going to be, it's not always a whole picture. Yes, Myra?
Side effects.
Side effects, right. What are the side effects going to be?
And what I was going to say to follow is, if my child has anxiety and ADHD, will stimulants make the anxiety worse?
Yeah. So what is going to be the effect of one versus the other? So we can talk a little bit more about that. In some kids, it does make the anxiety worse. In some kids, it helps a little bit. And it really depends a lot on kind of who that child is. If they're anxious, sometimes just not being able to pay attention and focus makes you more anxious, right? So if your medication's allowing you to kind of, I can do this, then you're not going to be as likely to be as worried about some things. But, in the other case, sometimes it does make kids a little bit, more irritable or have more of an effect on mood, and so it can go the other way too. Yes, Larry?
One of the other things that I've heard in my own family is the overprescription of drugs. So there's a stigma against kids who actually need it from getting it because there's this view that everybody's on it and only a small sliver need to be on it. For instance, my nephew absolutely needed to be on ADHD meds, and my brother was dead set against it, and he's a physician.
Yeah. I think many of us probably all grew up kind of in that time where ADHD was discovered, right? Like now everyone has autism, but if you go back 20 years, everyone had ADHD, right? And so there were a lot of prescriptions for ADHD that were probably needed, and then there were a lot that were probably not needed. And when you're treating someone with a medication that's not needed, especially the stimulant medications, it can lead to some, side effects and some scary stuff sometimes. So, so I think that stigma is there against medications, and then that's really hard sometimes to break through in a family. Yeah.
Another concern is that with adults is that they would overdose. Have the medicine and then overdose or sell it or
Yeah, and unfortunately I've had to, for some adolescents or for some young adults who've lived on their own where that medication really helps them, their ability to take it regularly or to take it responsibly and not, have their buddies come in and say, hey, has been a barrier to even being able to prescribe it. Yeah.
Setting them up for a dependency on something versus the concern of self-medication.
Right. Yeah. So there's a lot of families who will feel like, I want him to be able to overcome these things on his own. I want her to be able to learn to do this and manage this without a medication or a crutch. And so how can I get that to happen? And then I also don't want them to be, addicted to a medication. Okay, one more, then we're going to move on.
Could I do two real quick?
Yeah, you can do that.
One is the lethargy, or I don't want my kid walking around like a zombie. But on the opposite side, what my pediatrician told me is my child is less likely to self-medicate if we control a lot of the symptoms early on.
Right. So that's a big one, right? I don't want, the goal of medicating ADHD is not to say, oh, your kid was so hyper and inactive, well, now look, he's sleeping in the corner. Look how great that med works, right? Sometimes that's the answer, no. But that's not, that's not what we want. We don't want kids to be zoned out, to feel like their personality is different, to feel like there's something, off with how they're functioning. And then there is a myth, and that, oh my gosh, this is going to lead to addiction. And there is actually a lot of research that supports that when used appropriately, teenagers who take medications for ADHD actually are less likely to go on and have substance abuse difficulties, because otherwise a lot of times they're going to be more impulsive and or seeking something to help with that. And so we have to be careful, because some of the medications are still abused in adulthood or adolescence and adulthood, but it's definitely more likely that correct and appropriate treatment in childhood and adolescence leads to fewer problems later on with substance abuse. Okay, so let's see how many of these we got. This is the clicker, and I keep pretending it's the microphone. So I don't want my child to become dependent or addicted. I don't want my child to be drugged. I don't want to change his personality. I'm worried medications will change the way the brain develops. What's the long-term effects on the brain? I'm worried about side effects. Will he have to take it for the rest of his life? Family members. I read about a person who took them and something went wrong. I want my child to learn to manage her own behavior. So you guys got all of them. Yay! Dr. Hong did a good job. So here we go. So here's those 5 reasons again, and let's talk about them a little bit more in depth. Okay, so when the behavioral emotional difficulty is significantly impacting health and safety, I'm going to focus a little bit on attention and then also anxiety, depression, right? These are the biggest ones that we end up treating in our X and Y variations in clinic. And so we'll use these ones as examples. So if it's causing injuries to self or others, they're aggressive, they have self-injurious behaviors, they're grabbing at things that are going to be causing danger to themselves. He grabbed at the knife, he grabbed at the hot stove. That is risking his health and safety. If they are, impulsively hitting other kids or doing other things like that, if they're running off and darting, then clearly those are reasons that we would be worried about their health and safety with impulsivity and with aggression. Yes?
At what age do you start saying that these aren't, just being typical, they're so too little to get this stuff yet?
Well, it really depends on the age. I mean, you definitely want to think about what's typical impulsivity for that age group, right? I mean, even my 6-year-old in the parking lot, I grab her because, I trust she'd probably just walk beside me, but you still, many 6-year-olds are still very impulsive and might walk off or not have that sense of danger. So, but if my 6-year-old was running off every time before I could even get her to do it, and then that's a challenge even at 6. So the preschool age group is usually not a group that we treat as commonly unless there is pretty significant symptoms. But once they get into grade school, then all of these things need to really be considered. Definitely in the preschool age group, though, if it's causing a lot of problems, we talk about it. And then in terms of health in general, there are some kids who really have very poor attention span, even sitting down to eat dinner. They're up and down and up and down. They don't eat as much as they should. So it's definitely causing problems in terms of just intake. Restricted eating due to sensory or anxiety concerns. I only eat green foods, or I'm not going to eat this or that. And so if if anxiety or kind of obsessive compulsive types of behaviors are causing problems, if there's, we're causing lots of constipation and having issues because I'm too anxious to poop on the toilet at school, then clearly that's something else that is not so great for health and safety. The next one, and obviously and most frequently concerning to parents, is the effect on academics, right? And how it's affecting their learning and their academic set and performance in the academic setting. This is where also teachers will tell you things about, especially externalizing behaviors. The kids who are hyperactive, they're going to tell you about. The kids who are disruptive, they're going to tell you about. The kids who are anxious, they might tell you about, depending on what the manifestation of the anxiety is, right? Now, I'm not saying anything negative about teachers. Teachers stand in front of a classroom of a lot of kids, So the ones who are popping up here and there and causing difficulties are going to be the ones that are called to their attention. The kids who are more quietly inattentive, not being as hyperactive, they're looking around, maybe they just need to be refocused on their work, that is not as apparent to teachers. So it's not that they're clearly ignoring all the kids, but a lot of times it's harder to identify those challenges with attention when they're in a setting with a lot of kids. But basically, with these ones, it's how much time is spent kind of managing the behavior, like attention problems or anxiety, versus being engaged in the school or learning environment. If a child is really so distracted that they need to be redirected to task, 3 times as much as peers their age, then that means that they're probably not gaining as much. Or if they're not able to pay attention long enough to really hear the instructions and then still have challenges following all the different steps of the instructions. So is it affecting the rate of progress they're making in terms of especially what they're capable of? Are the attentional symptoms taking away from that? And then if they're in a speech therapy setting and so anxious that they're not even able to participate in that speech therapy, and the speech therapist is spending all of the time trying to get them to warm up instead of actually working on the therapy, well then, that's definitely affecting their ability to access therapy, right? When the behavior or emotion is impacting functioning in the family and community. We get in a fight every single morning because he can't get ready for school. And it takes us, 8 hours to get out of the house in the morning. If it's causing significant family conflicts, not able, we don't go to the restaurant anymore because it's too difficult to manage her anxiety in the restaurant, or it's too difficult to manage his behavior in the restaurant. Now, clearly that's another thing that's age dependent. I don't go to the restaurant a lot with my 2 kids either because it's too chaotic. But yeah, so these are, what is it doing in terms of impacting the family? In terms of social development and social interactions, this is something that a lot of families often don't worry as much about and haven't really thought about as much. So they worry about school, and clearly that's really important in school performance. But what about in terms of their social interactions? So if their impulsivity or attention span is affecting other kids such that they're annoying, right? That's that annoying kid who always impulsively grabs at me. That's the one who always, is bugging me, not fun to play with. I worry about those kind of things because if that impulsivity or some of that, he never pays attention to me. I talk to him and he looks off over here. That's not a good social partner, right? And so that can have some long-term effects then in terms of people wanting to be friends with you, wanting to interact with you. And so, so I worry about those things in terms of, what it's affecting in terms of their social interactions. And then a lot of times with anxiety, this is obviously really important. If there's social anxiety, they're not engaging in the regular setting, if they're not talking, if they're not comfortable enough to be themselves, then that's going to affect social development as well. And then, when the kids are expressing distress about their behavior, and this clearly comes in a big range. Many times in our X and Y variation kids, they don't express distress well because they don't have good expressive language, right? But sometimes kids will say things like, I don't know, I just always have firecrackers in my head, and why do I do this? Or why is this harder for me compared to other kids? Or I really wish I could talk when I'm there, but I can't. And so they feel like, they're expressing their symptoms and their anxiety. Obviously, self-injury and any kind of suicidal ideation or attempt is a clear indication that they're expressing or demonstrating distress and is a significant issue. Considerations for starting treatments, we always think about benefits versus risks, right? And so if you feel like the risks and the negatives are more than the benefits, then that is not a good choice in terms of medication. So we want to always think about that balance. There are benefits and risks to both, right? There's benefits to taking medication and benefits to not taking medication. And then there's risks always with taking medication and risks with not taking the medication. And so I think these are important things to think about. So I want someone to think about for 1 second, what would be a benefit of taking a medication? Yeah, the symptoms are treated, right? So that's one of the benefits. What about a benefit of not taking meds?
Symptoms continue.
Well, is that a benefit?
Oh, benefit, I'm sorry.
That's a risk, right? Symptoms continue. Yeah.
I read left to right.
No side effects. We don't have to worry about it. We don't have to pay for it. Yeah. Right? So that's a big benefit. The risks to taking medications are clearly the side effects, right? You guys have talked about that. But then the risks to not taking medications are that you're not getting those same treatments. So for each kid, there's a lot of different things on this list that can be a lot more specific. But these are kind of more details in terms of, what might improve, what some of the avoidances are, and then some of the risks for not taking them in terms of, the behavior might get worse, it might limit some of their opportunities that they have to do things, progress in school, it can cause the health and safety problems. So we talked about a lot of these things too. So I think that these are important things always, and for each kid, some of these are more important than others. Lab draws for some kids are, no big deal, right? For others, oh my gosh, we're gonna need a medication to get them to go to do that, right? And so that's important. Yeah?
I've heard a rumor, maybe you can clear it up, that taking Ritalin for one may preclude our children long-term from certain types of jobs. Have you heard anything like that before?
Can you repeat the question?
If taking stimulant medications might preclude them from getting certain types of jobs. Like if you have a diagnosis of ADHD, can you still be a pilot? And if you can, you still take it if you're, I don't know those rules.
The rule for joining the military, if you have ADHD, you have to have done well for a year or two, I think it is.
Without a medication? What about anxiety or depression? No. So you can't be on any meds for the military.
Just as a personal testimony, the military is the biggest thing, but most other jobs, like my husband personally has taken Ritalin since he was 4. Mm-hmm. He's now 42, and he's a very successful engineer for the Army because he couldn't be in the Army. So,
So I don't know the details of those things. I don't think, though, like Bill was saying, right, if they took them in childhood, Bill, it doesn't say you can't be in the military as an adult if they're not taking them anymore. Right. Like if you took it when you were in grade school, it doesn't mean, you're out.
You can't be on it and be in the
Right.
You can't currently be on it because one of our kids tried and couldn't pass the test.
Without it.
They do the whiz quiz right away, and that's how they find it.
The whiz quiz?
That's a good name for it. So then, in terms of, when we start medications, I think this is another important thing to think about. And this is very different for different families also. Just because you have symptoms present, that does not always mean, again, like this is a time for medications. As soon as we see that, oh my gosh, there's, a short attention span, right? There's a lot of other things we want to do and think about when we see that. Then the symptoms start to kind of mild to moderate impairments, moderate to severe impairments, and then we have a crisis. We're failing out, we have severe safety concerns, we're kicked out of school, we're in the hospital. So in, my ongoing work with this group and, just in terms of experience, it used to be that, we still get a lot of patients who present to our clinic in this setting, right, in kind of crisis or post-crisis or near crisis. And it's not hard to think about medications when we're here, right? And different families along the way have different feelings about medications. And I am really, obviously very supportive here of the discussion of the role it would play. But I'm becoming more and more aggressive, honestly, about making recommendations for medications higher up on that chain. Clearly not at the beginning, but watching, some of the problems that can happen as you get to more and more symptom severity, it really is challenging to see that these things have been going on for years, sometimes, often without, optimal behavioral and academic supports, but also without the right types of medications that could have helped many years ago. And so, it's really heartbreaking when we see this, and then you read the report from the psychology evaluation 5 years ago that said he was diagnosed with anxiety or he was diagnosed with ADHD or something else, and they recommended medications at that point, right? And so, I think it's always kind of important to try and assess with any provider where you are along this and think about, whether or not it might play a role earlier, definitely before we're in any crisis. This is what we just talked about, medications as the last option, and I am kind of concerned about that as an approach because it needs to be part of that pie again, but it should definitely be part of that pie before the pie is exploded. You know, I think it's also important to talk about, you know, other things before we even consider medications that we have to rule out. Pain, ear infections, dental problems that might be causing irritability or problems, constipation, headaches, vision and hearing problems, seizures, thyroid problems, sleep apnea. All of these are medical conditions that can lead to behavioral effects during the day and challenges in an academic setting and in day-to-day life. And so talking with somebody about all of these different concerns is important. So now what? Like, let's say, okay, we're going to think about, you know, I think we've gotten to a point of where we have behaviors that are causing a lot of distress, and we want to discuss a medication. Let's talk about what we're going to do next. So then you have to really identify the target behaviors. What's the goal of the medication treatment? What would you like to see improve? What difficulty is actually leading to the primary impairment that's leading to the you know, decrease in overall functioning. So again, here we have all of our different options of different things that can happen in the X and Y variations. And so we're going to be thinking about these as we think about this kid. So here's a kid, 7-year-old boy with XXY named Albert. Albert's mom calls, "Oh my gosh, I need some help. His behavior is getting worse. The school keeps calling me because of his behavior. Going to the grocery store or restaurant with him is horrible. We don't go anymore. He almost got hit by a car yesterday in the parking lot, and he got kicked out of speech therapy." So that's, you know, let's look at that in terms of, you know, are there considerations for medications? Are the safety pieces there? Yes. Is academics and therapy being affected? Yes. Is his family and community functioning being affected? Yes. So which medication would we start? Well, that we need definitely more information for, right? So yes, yes, and yes. Okay, so, you know, the school keeps calling me his behavior. That's really important to know why, right? For me to make any decisions and think about this kid, I got to know why. The why could be he can't sit through his group activities or circle time. The teacher always needs to redirect him to his work. He gets out of his seats. He grabs belongings of other kids. Versus he has meltdowns every time he transitions. He gets stuck on things. He's overwhelmed in the classroom. He doesn't want to do something when he walks out of the room. He's disruptive with peers. So these are kind of different kids, right? Different pictures for the same kid. So the first kid is this kid, right? He's kind of wound up. He's moving. He's more of an ADHD picture type of child. The second one is more this kid. I'm overwhelmed. I don't want to do this. I'm going to, you know, have some behaviors when I'm feeling stressed and overwhelmed. So these are, you know, this is a different type of kid. So, you know, then you want to really kind of think about the behaviors in another way. Going to the grocery store or the restaurant is horrible for him. Well, why is it horrible? He can't sit still. He's hyperactive. He touches or grabs everything. He runs down the aisle. He yells when he can't get something he wants. Or is it because he's really overwhelmed? He doesn't like new places or changes in routine. He asks over and over when they're going home. He melts down after 5 to 10 minutes. Those, again, are different kids, and so you're going to be targeting, as a physician, different symptoms. He almost got hit by a car in the parking lot. Well, is it because he ran off when he saw the ice cream store he wanted to go in? You know, that's impulsive. I'm going there. Or he ran off because he was at the dentist office. You know, I'm not going in there, right? And then, you know, he got kicked out of therapy. So why? Is it because of attentional difficulties in terms of therapy? He can't focus for long enough. He keeps getting out of his chair. Is it more, again, ADHD, attention distractibility types of symptoms? Or is it because that he's more anxious? He's agitated in the room. She talks really loudly. He's overwhelmed in there. He's frustrated and gets, you know, shuts down after speech therapy because he's very challenged by it. And then when challenging situations are there, it leads to a lot of anxiety and behavior challenges. So, you know, for this first little guy, the target behavior is really his attention span, hyperactivity, and impulsivity. And after hearing all of those pieces and then thinking about what we had, you know, talked about before, we want to rule out all the other symptoms related to medical problems and other neurodevelopmental or learning issues, we would start to think about medications for ADHD. And then we'd want to, really come up with some good goals to monitor the response to medication. He's having an improved attention span at school and during therapy. From how long to how long? Like, I want to hear sometimes some really, let's make some goals so we know as a treatment team, you guys with the monitoring behaviors, me with providing medications, if this medication is actually making a difference. Practical things, ability to tolerate going to the grocery store, being less disruptive or impulsive or disruptive in different settings. For this other little guy, we would be considering more of an anxiety medication, right? Because we're seeing a lot of symptoms that are more indicating that he's anxious. And so we might think about things like being better able to tolerate transitions, decreasing, repetitive behaviors when he's overwhelmed, being more flexible with changes, fewer kind of panic reactions that might lead to safety concerns. And then, when we're identifying target behaviors, we want to kind of figure out how we're going to measure them in terms of frequency, duration, intensity. For ADHD symptoms specifically, they're, kind of standard of care is to use very formal standardized questionnaires where you mark and rate the intensity of the different behaviors at baseline, and then as you start medications, you look at those same scores on those behavior questionnaires after treatment. Most pediatricians will use these. The most common ones are called the Vanderbilt or the Connor scales, and it's kind of common practice when people are prescribing ADHD medications to use these. I use them as well, and I'll look at the scores, and if I had to look at the scores and say what was more important to me, a change in the score or a change in what the family was saying about that child's behavior, I'm much more interested in what you're saying about some of these other goals and things we set where the behavior was being more impacted. The teacher forms are really helpful sometimes because it will give us an opportunity to get input from the teachers also. But if a score changes by 3 points and you say, I don't think this does anything, or a score changes by, no points, but you say, oh my gosh, I see a lot of improvements in these different types of settings, and the teacher scores kind of support that, then I'm more likely to say, okay, well, we're doing something positive. So I think they're a part of the tools. I don't rely on them solely for watching for improvement. Yeah.
Are you going to go over that same slide for anxiety, what the testing sheets are and how is that monitored?
Well, for anxiety, it's less. There are some behavioral questionnaires for anxiety, but they're not. They might be used by some people in monitoring response to treatment, but they're not part of a standard, if your pediatrician is treating anxiety, this is what tools they should use to monitor treatment. Anxiety is a lot more related to, response to treatment from more of a discussion perspective. And then individual providers might have different ideas. Yeah? We don't have any specific data to support that. Generally, with any kids with neurodevelopmental differences, we are more careful when we're starting medications in terms of dosing. So I always start slower or at a lower dose and go a little bit more slowly and then more conservative with changes because there do in some kids seem to be a more sensitivity to some of the medications, but I think that's all still very individual, and there are many kids who are on very standard doses of medication. So it's definitely not universal, but start low and go slow is often, we use for any kids with, I think should be used with anyone, anywhere, but definitely for kids with disabilities. This is what I do with the kids that are coming in terms of making a plan to figure out, I have kids, it depends on their age, but if they're old enough to kind of talk about their symptoms, then we do this. So we make a treatment plan. So we have a team captain, which is the child, obviously, and he signs up as team captain, and then we figure out the team members who are going to help us respond, figure out if this medication is working and helping him. And so he gets to name or she gets to choose the people who are on the team. Usually it's a parent and or parents, a teacher, or some kind of person involved in their academic life, sometimes a coach or something else. And then I'm like, could I be on the team too? And usually they say yes. Sometimes they don't. And so I thought, okay, well, that can be the team. And then we come up, you know, and we really talk about this is our target symptom. This is the medication name and the dose we're going to start with. These are what we're going to look for to see what gets better. These are the side effects to watch for. And then here's what to do if you need to call an emergency or 911 or, you know, other things, and you need to call for refills and when I want you to come for follow-up. And so this, you know, again goes home with the kid. I copy it for this chart, and it helps me know exactly what those specific symptoms were next time they come in. Because honestly, a lot of times when we're talking about attention difficulties and we're talking about anxiety, for some kids, you know, it can be really similar between different patients sometimes. And so I want to remember for me, okay, yeah, his symptoms were causing him problems getting out of the house. They were causing a lot of problems with his siblings, you know, and so we have those on there, and then that helps us really track and monitor what things are changing and which aren't. We talked about a lot of these monitoring tools as well. This is actually, you guys have probably seen or filled some of these out. This is an example of the Vanderbilt where it talks about, you know, you circle how frequently you see these different behaviors, never, occasionally, often, very often, and then this is what is added up to determine, you know, give us a number or a score to determine which of these symptoms and how severe they seem to be. You know, other monitoring tools that are important is, you know, sometimes there's formal behavioral logs that are kept in the school setting. Many parents will come in with all sorts of ways that they track behavior and tracking systems. You know, sometimes they'll keep logs, and it's helpful to, you know, for me when I'm managing behaviors to really see when we make changes what these changes might be in terms of behaviors that parents see. So, you know, when you come in with logs, it's really helpful. Sometimes it's just when something happens. He had an outburst. This is what happened before. This is what happened after. We're trying to figure out, you know, what happened. Other times, there's one mom I had who at night, she would each night at the end of the night just decide, or at the end of the day, just decide whether his behavior was green, yellow, or red. And so, you know, on any given day, there were different ones. But when you looked over time, we said, oh, we started a medicine here. And look, we went from red, yellow, green, red, yellow, green to, you know, green, green, yellow, yellow, green, yellow, red, yellow, green, 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 green. And so it really kind of like, in all pictures, like, oh, he's having definitely more good days than bad days, or the other way around sometimes, right? That one doesn't seem to be helping much. And then, you know, looking at and communication notebooks with schools are often parts of IEPs, OT, speech, therapy reports, other things that really help us monitor how everyone on that team feels like he's doing or she's doing. So finding a doctor, a lot of times, you know, your primary care doctor is the right person to start with. You can get then a referral from a primary care doctor to developmental pediatrician, child and adolescent psychiatry, developmental neurology. So all of these people are, you know, professionals who prescribe medications for kids. I also usually recommend asking questions and getting referrals from people who also have kids who are treated with medications. You know, for kids with different developmental differences, sometimes there are some doctors who welcome that and have experience with that, and other physicians who aren't as comfortable with it. And so, you know, so I think sometimes going to kind of the local family groups for kids with disabilities and asking who in your community treats their children. The autism groups, even if your kid doesn't have autism, those are professionals who are used to working with neurodevelopmental differences and probably are not going to look at you with a huh when you say he has XYY or he has Klinefelter syndrome. Or at least they're usually used to working you know, with different medical conditions that then they're more willing to look up and understand. And then obviously the AXYS Consortium, right? Now there are clinics that actually are going to be able to do treatment if there's a clinic near you. So the people who can't prescribe medications are psychologists. So, you know, there's a difference between a psychiatrist and a psychologist. Psychologists will sometimes make a diagnosis like ADHD or anxiety disorder and then make a recommendation that you talk to a physician, such as a psychiatrist, to initiate that treatment. But most psychologists, or all psychologists, to my knowledge, cannot prescribe medications themselves unless they have another license to prescribe for something else. Teachers can't prescribe medications. They sometimes can make recommendations. They shouldn't actually make any recommendations for medications. They should tell you about, you know, they can tell you about the symptoms they have. But I think many families get very offended when the teachers say, I think you should start them on meds. But if they are saying that, I would say, teachers have a good sense often of where that one child is compared to all the rest of the peers in their age group, right? So you don't want it to be their leading medication, but they're really important in terms of team members often in helping monitor response to medication. And then therapists as well can't prescribe medication. But like I said, they're all helpful as a team. Okay, so help your doctor be a good doctor. You want to think about all these things when you go in. What are the examples? Not just, you can never pay attention to anything. Morning is horrible. Well, why is it? Because in those ways, then we can really, come up with a better way to be able to help you. We did talk about this a little bit, start low and go slow. Obviously, one change at a time is really important. If there is anxiety and ADHD, we're going to pick whichever one seems to be causing the most impairment at that time. We would never start 2 medications at a time because if we were having side effects, we would have no idea what side effect it was from. And often treating one symptom really improves and can lead to improvement enough in some of the other symptoms. And so that you might not even need those medications. Sometimes we try and say, do it when things are stable, right? Well, if you're in a crisis mode or more in those situations where things aren't stable, well, then we just need to do it. But sometimes when say, it's time to start meds for ADHD, the time is not, and you've never tried them before, it's not at the very beginning of the school year when the teacher doesn't know him and when they're not going to be able to help. You want to wait until the teacher gets to know him a little bit. Or, we're going to do it, we're going to start a medication for anxiety, right at Christmas break when, all chaos is happening and we're going here and we're going there. Well, if anxiety is getting worse because you're because of other things that are going on, it's going to be really hard to determine response to medications. That obviously can't always be, be considered depending on the situation. Usually, it depends on the medication. Some you can notice improvements sooner than others, but I think it's always after a couple weeks really important to check in and reassess any kind of changes. Some meds take 4 to 6 weeks to even really see the maximum benefit. So, making dose changes here might not be the right time. For various medications like SSRIs, the serotonin medications, a lot of time you want to wait until later, unless there's a lot of problems earlier on. So these are some of the things that you guys should ask if you're talking to doctors about meds. What are the side effects? What are the rare side effects? If a side effect happens, what do we do? Who do I call during the day, after hours? Do we need to take it every day? What if I miss a dose? If I will run out or want to stop, what do I do? Can I stop it right away? Do I need to wean down? Those are all, and they're very different depending on each medication. But it's important for you to know all those things about whatever medication you start. And then obviously follow-up visits are different, and different physicians are comfortable with different intervals, and different physicians are also comfortable with different amounts of time that is spent on the phone, and or whether nurses are involved in medication management. So it's going to be very different depending on who you see. But it is important to come, and I feel like there are some things we can manage on the phone, but it's challenging when we never get to see the patient, because you have to be able to lay your eyes on those kids or those adults to really get a good sense of what the response is, and to be able to talk to them about how it's affecting them too. Sometimes we really need to do monitoring for side effects in terms of examination, as well as lab monitoring for some medications. Not usually for the medications for ADHD or anxiety do we need to do labs to monitor, but more for some of the mood stabilizing medications or antipsychotic medications. Sometimes we can also do appointments without the kids present. And so if you really want to talk about the meds and get a lot of information, and the kid has to go to school, as long as there's with the approval of the physician, there are sometimes we can do visits without having to have the patient there. And so that also is an option that we sometimes do. Okay, so, we talked about this already. Attention problems are not always ADHD, so I always think, especially in this group of conditions, we want to think about cognitive and learning impairments and that role on attention. We want to think about anxiety, we want to think about sensory sensitivities, and we want to think about all those medical considerations as well. If we're comfortable, then, you know, and we're going to actually talk about the different medications for ADHD. There's two kinds of medications. There are stimulant medications and non-stimulant medications for ADHD. Ritalinos do not actually exist, but in the 80s, I bet they did. And, you know, basically for stimulant medications, this is the one most families are most fearful of. Oh my gosh, you know, I don't want to start them on Ritalin. And so if you use the word Ritalin, a lot of times it really, you know, kind of brings back all these concerns that Larry brought up about, you know, the stigmatization of medication treatment. The generic name for Ritalin is methylphenidate, and methylphenidate actually comes in a ton of different brand names, Concerta and Metadate, and the form of it is Focalin, and so all of those are really the same as the generic methylphenidate, just packaged in different ways by different drug companies to be dispensed in different ways as well. And then the other big class is the mixed amphetamine salts, which is, or the, you know, that second class, which usually is heard as Adderall. There's a newer one that's called Vyvanse. And then there's always new variations of these that are coming out at different times as well. You know, when someone talks about stimulants, what do you mean a stimulant? In general, you know, this is very basic, but you know, the frontal lobe of the brain is your part of your brain that's involved in executive functions that many of you guys have probably learned about at this conference that can be decreased in kids with X and Y variations. And part of executive functions is inhibition and attention regulation and working memory. And so a lot of times this can be dysregulated when dopamine levels are not as active in that frontal part of the brain. Stimulate that frontal part of the brain so it kind of wakes up those mechanisms so they start to work. So when someone's hyper, parents say, I don't want to start them on a stimulant. What do you mean? That's going to make them worse. And the whole idea is it makes it so that you stimulate the ability to inhibit, right? And so that's kind of what we're not stimulating the child. So the target behaviors here are all these target behaviors related to attention. It turns them into children that look like this. Not really. So the benefits of the stimulants, and a lot of times when we're talking about meds, they work the day you give them. If you miss the dose, you miss the effect of the medication, but it's not necessarily dangerous. So some people use these only during the week for school. Some people use them only for baseball practice because that's where the symptoms are more significant. You know, and so you can use them more flexibly. Most of the time for kids, I say, you know, definitely give them during the school week. Give them during the weekend at the beginning so you can see as parents what the effect is, right? Because some of these only work for long enough until they get home from school, and you guys should really be able to be seeing what's happening with the medications. But then if you decide, you know, we don't need it on the weekend, well, that's fine on the weekend. You know, for many with X and Y variations where energy and fatigue is a constant concern or really seems to be more impaired compared to other kids, there are many, I wouldn't use it just for that, but one of the benefits that many patients will talk about is that, wow, it's not, you know, it helps me with my attention span, but it also just helps me feel more awake, right? And so it is obviously a stimulant does do that. They use it to treat things like narcolepsy and other things as well. And so, you know, I think sometimes for this group, it can be a helpful treatment for those symptoms as well. And honestly, stimulants for managing attention and impulsivity are often the ones that work the best. They work really well, and they have for a long time been around and being used for treatment of ADHD symptoms for, you know, over 50 years, and really seem to be those that are most effective. Yeah.
Do you recommend cardiac screening before?
I don't for all unless there's any concerns. If there's any history of heart disease, either in the child, obviously in the family with sudden death, any concerns of any symptoms related to arrhythmias or funny heartbeats, then I will. But otherwise, I don't. Would you say anything different, Dr. Alan Reese? Do you do cardiac screening before you start stimulants? Okay. So he's the child and adolescent psychiatrist who also treats many patients. So I just want to make sure I'm not saying anything differently. That's not supported. You know, the risks with stimulants are that they suppress appetite. And so when they're active, they actually suppress appetite. They can suppress sleep if they're still active when it's time for sleep. So, you know, the way they work, depending on whether you have a short-acting form, some only work for 4 to 6 hours, some work for 10 to 12 hours. When it goes up and it's active, it usually means that they're going to have more problems with sleep and less appetite. Not as much for some as for others. And then as it comes down, you know, and maybe it's time to sleep over here, they should be able to fall asleep. If it's bedtime here and you're still going like this, then you might have problems falling asleep. And so, you know, so it's really important to have an understanding and know that, you know, where and which medications you use have to fit into the pattern of your child. For some kids, it can lead to some irritability. Not for all. Sometimes in some kids, it helps them kind of regulate some of that frustration tolerance and dampen it down a little bit. Some families and kids will feel that they're more flat emotionally. You know, some kids who are used to being kind of that class clown and hyper and a little bit impulsive and funny, and if it dampens that, then they don't feel themselves, and so that's really important, right, to try and help them make sure that it, you know, it's still helping their attention, but it's not dampening their personality. Headaches can rarely happen. Sometimes if they have an underlying tremor, it can lead to a little bit of exacerbation of that. For some kids who are really kind of focused already on picking and nail biting, it can make a little hyper focus on that stuff. And then cardiac concerns, but only if there's underlying cardiac abnormalities, so that's where I would screen. Yeah.
Is there any research on the difference of stimulant medications for girls with inattentive type versus
versus more hyperactive impulsive?
Yeah, I think I read somewhere that it was a little less effective, but then other treatment seems to say they recommend for everything.
Right. No, you know, I don't, if they're hyperactive impulsive versus inattentive, and this is the class we're going to work with, I don't know of any research that says, you know, for trisomy X, one works better than the other. And I, again, want to think about all those other things that might be making them inattentive. Right? So sometimes some of the things that make them inattentive might be more anxiety, and then that way this might not work as well. There's myths and realities. So myths are that stimulants stunt your growth. There is some evidence to support in long-term trials that in typical kids with ADHD, long-term treatment can lead to a 1 to 2 centimeter decrease in height. Most of the time for the populations in here, that is not at all a concern. But honestly, I think a lot of the times when kids aren't growing as well is because they're not eating as much. And so, and it's honestly not always a concern, right? I mean, the more calories you eat, the more you're going to grow. So if you take a normal population, a lot of times I think all of our adolescents overeat. So maybe this is more normalizing what growth should be. But we generally, I don't have any concerns about that. But you watch growth carefully, right? And if growth and weight gain and all of these things, this is why we need to have follow-up. If those change, then we need to make adjustments. And then we talked already about the leading to addiction piece. Okay, I think it's time to go, but let me just talk very briefly about anxiety, and then there's a lot to talk about. But this one is, the SSRIs are the ones that we most commonly use for anxiety. Celexa, Lexapro, sertraline, Zoloft, fluoxetine, Prozac. These are the ones that I use most frequently and that are most frequently used in the pediatric population. There's a lot of other ones as well and newer ones, but I usually stick with these because I know how they work and I know their safety profile in kids. All the symptoms that they treat are over here: anxiety, shyness, withdrawal, worries, fears, panic attacks, irritability, depression. So again, depending on how severe these different symptoms are or what's present in which kids, then we would talk about whether or not this class might be right. They generally work by increasing brain serotonin levels. They often also work on other mechanisms in the brain as well, but this is the general idea, is that the SSRIs inhibit the reuptake of serotonin. So once serotonin is released into a synapse, it sticks around for longer if it can't get back up, and that sticking around for longer leads to more stimulation of the neurons that are responsible for mood and regulation of anxiety. So these are all the potential benefits, and we have already talked about these, but you know, some of the things that I think are more practical in terms of thinking about improved mood, fewer outbursts when they're agitated or frustrated, you know, abilities to transition, worries and perseverations. A lot of times, and one of the really important ones, not just for triple X, but primarily for triple X, but also for XXY and XXY, or XYY and XXYY, is you know, some of the selective mutism or the impact on speech and social engagement, right? And so there's a lot of time that there's an anxiety component to that difficulty with communication already with their underlying speech and language disorders, and then that can be really lead into a cycle where there's more and more social isolation or withdrawal, and or something that sometimes is called selective mutism, where the kids just don't talk in school settings. And so even for very young children with triple X, 3-year-olds who haven't talked, 4-year-olds, 5-year-olds, we've treated with SSRIs when the selective mutism and the symptoms of that have been really severe. Appetite changes can happen. For some it increases, some it decreases. Usually it's much less significant compared to what the stimulants do to decrease appetite. Sometimes it causes insomnia. That usually wears off after a little while, but obviously we don't want to disrupt sleep because then that can lead to further problems with mood. Nausea or GI symptoms sometimes. Usually if you take them with a meal, it's not as common. And then adults worry about, you know, decreased sexual drive or impotence, and you know, a lot of times in our kids, in younger kids, that's not an issue. So the other medications for anxiety, a lot of patients or parents, when we talk about anxiety, the concern is, oh, they want to drug them so that they're not anxious. And we think about, for adults, anxiety medications such as Xanax or Valium or, you know, those other ones. Those sometimes play a role, but usually they're not the ones that are used and chosen for kids, because they're also ones that, you know, work when you give them and then wear off. And we don't want kids to be in a pattern of, oh my gosh, I'm anxious, I need to take a medication, and then, oh, that helps me feel better, right? We want them to be able to learn strategies and have a more constant level of anxiety control rather than this up and down. However, there are some instances in terms of panic attacks where they might be really helpful and needed, or situations like we're going to the dentist. We have a big stressor we know is going to challenge this child. We're going on an airplane ride. That using these medications on an as-needed basis and talking about the situations when to use them, you know, can be a helpful part of a treatment plan. But in isolation, I don't usually use these. And then there's other meds we're not going to talk about, but these are for more significant behavioral regulation issues or mood disorder types of issues. There's definitely other medications that can come into play and that can be helpful if needed. And then this is the story of life. Yes?
Saw that wild and odd behavior, one of the side effects was SSRIs, but I never see mentioned is to uncover bipolar disorder.
Right. So those who, there is some support that if there is an underlying predisposition to bipolar, that it can lead to kind of uncovering that in some individuals. Family history and knowing kind of what's been in the family as well, where bipolar tendencies can tend to, you know, can help us guide medication choices also. Okay, so I think we're running late, but I'll take 2 questions.
How common is it for kids with, you know, with variations to take both the anxiety and ADHD medications?
You know, I am very biased because families come to me usually with more significant levels of concern when we're treating. We see a lot of kids that we follow just for developmental concerns, but you know, so I see a bigger population of kids who seem to be more effective compared to what we know we see in the general population. I definitely have some kids who are on medications for both. I can't really give you a percentage, but you know, when both are present, there are some medications that sometimes can help both. You know, Wellbutrin is one that for sometimes anxiety and attentional symptoms that aren't that bad, it helps, you know, and really can target both of them. Most of the time I say let's target and figure out which is the primary issue. Let's treat that. Let's see what happens after we've gotten that under control before we decide whether or not we need to start another. And if we do, let's be careful and make sure we don't have interactions with the other one.
Thank you.
Yeah. One more question? Yeah.
I'm embarrassed to ask this, but what role could caffeine play as a medication, a drug for kids?
Yeah. So, you know, caffeine used to be kind of thought of as the poor man's test to whether or not they were going to respond to a stimulant. So, okay, well, you think your child has ADHD, give them caffeine. If they get more hyper, it's not ADHD. If they get less hyper, it is. You know, so, but that's not really true. But there are some kids where a little bit of caffeine can help calm them down. So, you know, I did have one mom who used to give her daughter a shot of Mountain Dew in the morning, and then it turned into a shot of Mountain Dew in the morning, at lunch, after school, and then so, you know, and it helped, and it can, you know, it acts on our brain. I don't think caffeine is good in that it can be, you know, it is, you get addicted to it, right? You get physiologic dependent on it, and so then when you try and take it away, they get headaches and withdrawal symptoms, and so, you know, and that doesn't happen with the stimulants. And so, you know, if a teenager's drinking a cup of coffee instead of taking, you know, a dose of medication every once in a while, but if it's used as like a chronic treatment, I'd rather, if you're using it all the time, then get on something that's going to be, you know, more consistent and a little bit better. But we all wake up with caffeine, right? Yeah. Okay, so thank you, and I'm here, and I appreciate you all being here.